Remember, dry the skin well after cleansing so that the dressing will stay in place, and be sure to assess the client for any allergies or sensitivities to adhesives, and use hypoallergenic materials as needed. Before you begin the procedure, explain it to the client and evaluate his ability to cooperate with you as you change his dressing. Have assistance available as needed. Now let's go ahead and demonstrate applying a dry, sterile dressing to an adult client's surgical wound. We'll assume the nurse has checked the provider's orders, screened the client for allergies, and explained the procedure to the client. The nurse assembles her equipment. She will need a towel or waterproof pad, a bath blanket, clean gloves, a moisture-proof biohazard bag, adhesive remover, a sterile dressing kit or the appropriate dressing materials, sterile drapes and the prescribed cleansing solution, tape, straps, or a binder, sterile gloves, and any other materials the provider specifies, such as ointment. Next, the nurse provides privacy and assists the client into a comfortable position that allows good access to the surgical wound. She protects the bed linens with a towel or pad. With the bath blanket, she covers the client appropriately, except for the area where the dressing is. She sets up the disposal bag for easy access, then washes her hands and puts on clean gloves. Gently, she removes the existing dressing, applying counter-traction to the skin as she peels the tape away, all the while being careful not to pull on the sutures or on any drains. If the adhesive were to resist removal, she would use a solvent to loosen the tape. She places the removed dressing in the disposal bag without touching the outside of the bag and noting the characteristics of any drainage on the dressing. She then removes the clean gloves and washes her hands. Next, she assesses the wound so that she can later document her findings. She opens all sterile supplies and pours the cleansing solution into a sterile basin. She puts on the sterile gloves, then carefully cleanses the wound, following the provider's orders or the institution's policy. Note that she cleanses it from the area of least contamination to the area of most contamination, using one sterile swab, gauze, or cotton ball for each stroke. If this wound had a drain, she would cleanse it and the surrounding skin last. She dries the area completely with gauze pads. If any medication has been prescribed, she would apply it. If this wound had a drain, she would apply pre-cut gauze around it, extra gauze below it, and add dressing material over it to collect drainage. Next, the nurse applies the sterile dressing over the wound. For larger wounds, the final covering is usually an abdominal pad to absorb drainage, support the wound, and protect it from trauma. Finally, she secures the dressing with tape or straps. If the client has fragile or sensitive skin, she'd be sure to use paper tape. After changing any dressing, you'll remove your gloves and dispose of them in the proper receptacle. Make sure the client is comfortable, then wash your hands. Document your dressing change, your assessment of the wound, any drainage or fluids on the dressing you removed and their color and odor, any wound care you provided, how the client tolerated the procedure, and any other concerns or observations in the client's record. Some institutional protocols also require that you put the date, the time, and your initials on the new dressing so that there is no question about when it was last changed. Of the many types of dressings available for various types of wounds and various stages of healing, transparent adhesive films or wound barriers have unique properties that make them especially suitable for superficial wounds, as well as partial thickness ulcers and burns. Transparent wound barriers act as a temporary skin. They are impermeable to fluid and bacteria, but allow oxygen and moisture vapor to pass through them, thus allowing the wound to breathe. These properties also make a transparent wound barrier a good choice as a cover dressing for autolytic debridement of necrotic tissue. They seal in wound fluid, thus allowing the enzymes in the fluid to digest the necrotic tissue. The moist environment they create also helps to speed epithelial cell growth. These dressings cannot absorb moisture, however, so they are best suited for wounds that have light or minimal exudate, or for superficial wounds, such as stage 1 and some stage 2 pressure ulcers, as well as minor burns and lacerations. They provide protection against friction, and because they are transparent, they allow easy assessment of the wound. Transparent film dressings are also used to cover the intravenous catheter insertion sites, Again, because they facilitate visualization of the site without removing the dressing and risking bacterial contamination. Because they are self-adhesive, no secondary dressing is required, and they eliminate the need for dressing changes as long as the dressing remains intact. Because they are waterproof, the client can bathe or shower without affecting the wound or the dressing. And because they adhere only to intact skin, they can be removed without disrupting the wound. Prior to applying a transparent wound barrier, you will check the provider's orders and follow your institution's policy for the specific procedure. Before you begin the procedure, explain it to the client and evaluate her ability to cooperate with you as you change her dressing. Have assistance available as needed. Now let's go ahead and demonstrate applying a transparent wound barrier to an adult client's superficial wound. We'll assume the nurse has checked the provider's orders, explain the procedure to the client, and review the manufacturer's instructions for applying the dressing. The nurse assembles her equipment. She will need clean or sterile gloves, scissors, alcohol or acetone, a moisture-proof bag, wound cleaning supplies as needed or prescribed, the wound barrier dressing, and paper tape. Next, the nurse provides privacy and assists the client into a comfortable position that allows good access to the wound. She assesses the wound, any drainage, and the stage of healing. She then washes her hands and puts on clean gloves. If necessary, she would clip any hair around the wound that might keep the dressing from adhering. She then cleans the wound and surrounding area as prescribed and dries the surrounding skin with sterile gauze. Next, the nurse removes part of the paper backing on the dressing and applies the dressing to at least 1 inch, that's 2.5 centimeters, of surrounding skin at one edge of the wound. Gently, without stretching the dressing but still keeping it free of wrinkles, she lays the rest of it over the wound, working from the edge where she began toward the opposite edge. She then frames the dressing with the paper tape to keep the edges from curling up or becoming loose. After applying the dressing, you'll remove your gloves and dispose of them in the proper receptacle. Make sure the client is comfortable, then wash your hands. Document your dressing change, your assessment of the wound, any wound care you provided, how the client tolerated the procedure, and any other concerns or observations in the client's record. The wet-to-dry dressing is used occasionally for large open wounds, the result of infections or evisceration. For stage 4 pressure ulcers, the current treatment plan is occlusive foam dressing. Prior to starting, explain the procedure to the client to allay fears and ensure cooperation. Be honest about any discomfort that might be involved. The client should be offered pain medication early enough for the medication to take effect before starting the dressing change. Additionally, note the client's allergies, especially to adhesive tape, povidone iodine, or other topical solutions or medications. The items needed for the procedure are absorbent gauze pads or a gauze roll, sterile saline or ordered liquid, sterile basin, large protective gauze, sterile gloves, binder, or straps to hold the gauze in place. Often this dressing is used for an open wound, which is not easy for some clients to look at. Offer to let the client see the wound, perhaps with a mirror, or shield the wound from view if the client requests this. Wash hands thoroughly before beginning the dressing change using soap and water or alcohol-based rub. To remove the dressing, put on non-sterile gloves. Depending on the depth of the wound and the wound site, additional protective personal equipment may be needed, such as goggles, gown, and possibly a mask. At one time, the practice was to remove the dry dressings in order to pull away dying tissue. We now know that this also tears away new tissue growth. To avoid damaging new tissue and putting stress on a healing wound or incision, the dressing should be moistened so that it can be gently pulled from the wound. Loosen the soiled dressing by holding the client's skin and pulling the tape or dressing